We're going to talk about some common challenges of breastfeeding and also how to express and store breast milk safely. One of the most common challenges of breastfeeding is sore nipples. And contrary to popular opinion, nipples don't need to toughen up. It's about making sure that the nipple is in the right place in the baby's mouth so that it doesn't suffer any trauma. So the most likely explanation for sore nipples is that there is a latch or attachment problem, where the baby has not taken the nipple far enough back into the mouth and does not have a good mouthful of breast tissue. But other reasons for sore nipples could be tongue tie, thrush, especially after a period of trouble-free nursing, baby teething, misuse of pumps or products. It could be blebs or blisters, skin complaints, vasospasm, or even Raynaud's syndrome. However, the latch or attachment is the most likely solution. So to help sore nipples, first of all, enlist the help of a trained breastfeeding supporter. The mum can use measures to assist healing and dealing with pain, for example, ibuprofen as analgesia. Expressing a little bit of milk before starting a feed so that when baby goes on, the letdown has already happened. She might want to breastfeed from the least sore breast first, again so that baby has that initial part of the feed on the better breast. Between feeds, she might want to wear breast shells to reduce friction on the nipple, and laid back positions for feeding might be more comfy. Putting a warm flannel on the breast just before a feed again will help with the letdown, and having ice on the nipples before a feed might help with a little pain relief, although we don't want to apply ice directly to nipples. Hydrogel pads can be used between feeds or fresh air as well. And for damaged nipples where there is actually a crack, moist wound healing should be considered. This is where we try and heal the crack from the bottom up rather than having a scab. You can use nipple creams for this, but they can be very expensive, and Vaseline has been shown to be just as effective for this. So you would wash cracked and damaged nipples in a mild soap and water 3 times a day to help reduce infection, or in the shower as usual. And then you apply a small layer of Vaseline or nipple cream over the damaged nipple, and that keeps it moist throughout the day, which helps with the healing. Another very common challenge is engorgement, and we will expect this to happen around day 3 to 5 first of all, when the milk comes in, as the colloquial term is used. But it can also happen later in a breastfeeding journey due to blocked ducts, and can lead then to mastitis. So to help with engorgement, we want to keep mum and baby together and encourage baby-led feeding, responding to those feeding cues, so we want to be feeding frequently. Pumping or hand expression between the feeds can help the milk flow easily. And reverse pressure softening can improve the ability of the baby to latch. Increased skin-to-skin contact will really help, and also getting help from a breastfeeding supporter to ensure an effective latch. Before feeding, mum can soften the breasts with warm showers or warm flannel. And between feeds, we'd apply cool, such as a cool pack or green cabbage leaves, to the breasts between feeds. Yes, cabbage leaves does seem to be an evidence-based solution to engorgement. Mum can take pain relief, something like ibuprofen is completely safe during breastfeeding. And also think about relaxation techniques for her. She might want to do some breast massage, or she might want to lay on her back so that it helps relieve the swelling by elevating the breasts. When breasts have become engorged, they can lead to having a blocked duct. This also can happen when there's pressure on a particular part of the breast, for example, from a car seat strap. It may present as a lump in the breast, which is firm and tender or painful. Generally with the blocked duct, there's no other symptom present, so it wouldn't present as a fever. But pressure on part of the breast from a bra, particularly an underwire bra or an infant carrier, or just the way she keeps holding her baby, might cause this. Sleeping in a certain position, again, can cause a blocked duct if it puts pressure on the breast in a particular part, as can incomplete milk removal. So to treat a blocked duct before it gets to mastitis, we want to encourage frequent feeding on that breast. Hand massage over the area. We want to compress the area of the blocked duct as soon as feeding occurs. Mum might feel that a hot compress works really well for her, and an electric toothbrush or a comb over the affected area can really help for massaging that blocked duct out. Lecithin supplements can be helpful if recurrent blocked ducts occur. And also think about rotating the baby's feeding position. They can feed from 360 degrees, so feeding in a different way may help the baby to release the milk in that blocked duct. If a blocked duct or engorgement is not treated, it may lead to mastitis. This can show as inflammation and swelling of the breast, with colour changes. It might be hot, tender or painful. There may be streaks on the breast. The parent may be suffering fever or flu-like symptoms and feel really very unwell. There's likely to be pain on feeding and milk may appear clumpy. If mastitis is confirmed, then ibuprofen will still be appropriate. And mum should try to continue feeding or expressing as we need to move the milk out of the breast to clear the mastitis. Having warmth before a feed, for example a warm flannel, and cold after, for example an ice pack, will really help, as will gentle breast massage and varying the position of the baby or the pump. Mum will need to breast and avoid any external pressure on the breast. If after 24 hours these self-help supports have not worked, she will need to contact her GP, as antibiotics may be needed. Thrush may appear in a baby and a mum together, and it may appear after a few weeks of trouble-free breastfeeding. It's rarely there at the start of a breastfeeding relationship in the early days. In the baby, you may see creamy white patches in the mouth, on the tongue, or far back and in the cheeks. Do be aware that having a milky tongue, though, is very normal in a baby, so do not mistake that for thrush. In thrush, the patches do not rub off easily, and they'd need redness or bleeding if they are rubbed. Baby's tongue and lips may have a white gloss, and they may be reluctant to nurse or may pull off at the breast. You may hear clicking sounds when feeding, and the baby may be fussy or gassy, or have redness and raised dots in the nappy area. In the parent, they may have a sudden onset of nipple pain after a period of pain-free nursing, with shooting pains that last after the feed has finished. They may well have cracked nipples, which is where the infection has got in. And nipples may be itchy or burning and may show colour changes, be shiny or flaky and have a rash and tiny blisters, but nipples may also appear normal. Nipple or breast pain would still occur even with the correct use of an automatic electric breast pump. She may have a vaginal yeast infection as well. Treatment for thrush involves a swab test for confirmation and then a treatment plan such as the one provided on the Breastfeeding Network site. Both the parent and the baby should be treated at the same time, and positioning and attachment help should also be provided. Scrupulous hygiene, including separate towels for all in the family, will help. Sometimes parents can find that taking acidophilus capsules or reducing the sugar or yeast in their diet may help if thrush occurs. Tongue tie, or ankyloglossia, is where the membrane below the tongue is shorter or thicker or more restricted than we might expect. Babies may be able to stick their tongues out past their bottom lip, but may not be able to do this, or the tongue may not reach the top of the mouth when crying. It could form a V-shape or a heart-shaped tongue, and there may be difficulty in getting a wide gape. There may be difficulty latching, which results in sore nipples, pinched or white nipples, and poor weight gain for the baby, and that results in poor milk supply. There may be a clicking or a smacking sound when feeding, and the baby may gulp or choke on flow, have wind, hiccups, reflux with any feeds, and dribbling, even during bottle feeds. There may be long or very frequent feeds and a tired baby. If there is a suspicion of tongue tie, this should be referred to an appropriate practitioner, either within the NHS or from the Association of Tongue-Tie Practitioners. Many new mums will worry about whether they have low milk supply, and several things they may worry about are not necessarily indicators of low supply. For example, the baby having short feeds, the mother having small breasts, a baby who won't go down, mum not leaking or stopping leaking, baby feeding frequently, and little milk being expressed or pumped. None of these are necessarily indicators of low supply, all can be completely normal. The real indicators of low supply are weight gain and nappy output. So we need to look at how much a baby weighs and whether they are keeping to their centile charts and whether they are having an appropriate amount of wet and dirty nappies each day. If both these things are happy, then the milk supply is meeting the needs of the baby. Likely reasons for having a low supply. The most likely reason is feeding the baby additional milk and feeding the baby away from the breast. As we know, after day 5, milk changes to a supply and demand system. So the more milk that a baby has from a bottle or away from the breast or is formula milk, the less signals are going through to that mum to tell her to make more milk. Inefficient milk transfer can be a reason for milk supply. So if baby has, for example, a tongue tie or poor positioning and latch, they are on the breast a lot, but they are not actively removing milk from the breast, then again, supply and demand means that the more milk won't be made. Occasionally, there are physiological reasons why there is low supply, and we think this is between about 2 and 4% of the population. Polycystic ovary syndrome may be a reason for having oversupply, and it may be a reason for having low supply. Someone who's had breast surgery may be at risk of having a low supply if ducts have been cut during that surgery. And there may be hormonal reasons, for example, thyroid. However, this is around 4% of the population for all of those reasons, so the majority of women can make enough milk for their baby if they are supported to do so. So if there is low supply, we need to support the baby to attach well, feed frequently and transfer milk efficiently. If the baby cannot do this, then it's appropriate to add in additional expression or pumping. When you are thinking about breastfeeding support, we need to think about the 3 keeps. We need to keep that baby fed, we need to keep the milk flowing, and we need to keep baby close, because that closeness will help with the hormone oxytocin, which will help with the process of breastfeeding. So the rules of breastfeeding support are firstly to feed the baby. That is the most important thing. Secondly, to protect supply. So if baby is being fed away from the breast, we need to add in additional expressing and pumping. And then to give or seek additional breastfeeding support. Expressed milk may be taken by hand expressing, or by pump. Here are the instructions of how to express milk by hand, and they will also work for expressing colostrum antenatally, although do warn parents if they're doing this to expect very small amounts. We use 1 ml syringes to collect colostrum antenatally. If they're choosing to use a pump after the milk supply has established, they have some choices around this. You can use a hand pump or an electric pump. Hand pumps are very simple, easy to sterilise and small to take around. Electric pumps can be easier in the long term because they are more efficient. With electric pumps, you can use single or double systems to pump from one or both breasts. Most systems that are available in the shops are what we call open systems, which means there is a possibility of the milk flowing into the pump motor parts. This means that open systems should not be shared between different mums second hand. However, closed grade systems, for example those used in hospital, can be hired, and these are the most effective way of taking milk out of a mother's breasts. So if she has a reason to pump very frequently to either increase her supply substantially or, for example, to provide milk for babies who are in NICU, neonatal intensive care, then an electric hospital grade pump may well be the solution. They can be hired via these numbers. If a mum is needing to pump frequently to increase her milk supply or to provide milk for babies who are not feeding at the breast, she can choose to do something called power pumping, which is where you are really trying to work hard on increasing the amount of milk expressed by mimicking a baby. Another option for pumping, though, is to pump for a very short amount of time, a micro pump for 3 to 5 minutes after each feed that the baby has. Both of these will be ways of trying to increase the milk supply by telling the brain to make more milk. Once breast milk has been expressed, either by hand or using a pump, you need to consider storage. Because of its antibacterial properties, breast milk can be left at room temperature for a few hours. So if mum is expressing at night, she can simply leave the milk by her bed for you to collect. If milk is not going to be used in the first few hours after expressing, it's best to put it in a refrigerator or a freezer. We often use the rule of 6. So milk's being stored at room temperature for up to about 6 hours, at the back of a fridge for up to about 6 days, and in a deep freezer for up to about 6 months. However, you will see on the screen the variety of different conditions which may affect these procedures. If milk has been frozen, you'll need to defrost it in a fridge and then use it within 24 hours of it defrosting. If you have warmed milk that has been in a freezer or refrigerator, you'll need to use that within around an hour, as warming will help the bacteria to start to multiply.